Well, thank you, Liz, for welcoming some of these participants and being mindful and respectful of everybody's time here today. I'd like to kick things off and welcome you all to today's webinar. My name is Vanessa Carson-Sasso, and I am the co-I and treasurer for this project and also the treasurer for the National Alliance of HIV Education and Workforce Development, NAHEWD. And here with us today, as you just heard from Liz Lazo, she's our secretary for NAHEWD and also the program manager for this project with ORN. And today's webinar is the third session in a 7-part webinar series that we are hosting in partnership with the AIDS Education and Training Centers program and the Opioid Response Network, ORN. This session is being recorded and we will make the recording available on our website in about a week. So the National Alliance of HIV Education and Workforce Development, or NAHEWD, is a membership organization of the 8 national AATCs and the 8 regionals and the 2 national AATCs. And we were established in 2010, and we support the work of the AATC program, which is a HRSA-funded Ryan White HIV/AIDS program. And really, we're looking to maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care, and treatment, and medical management for people at risk and living with HIV. And so NAHEWD collaborates with many organizations in order to promote and educate about the great work of the AATC program. So since 2018, NAHEWD's been part of the Opioid Response Network, or ORN, which is funded by the American Academy of Addiction Psychiatry. It's a SAMHSA grant, and it is really looking to address the intersection of HIV and opioid use disorder. And that's really NAHEWD's explicit role in this TA network. And ORN was created to support efforts in addressing prevention, treatment, and recovery of opioid use disorder. And so ORN provides free resources and technical assistance in communities across the U.S. and its territories. So we encourage you to go ahead and click this link and visit the ORN network website, and you can just learn more about the ORN network or submit a TA request directly through the website if that's something you need. So we are offering continuing education credits for this webinar series. You must please, of course, your feedback is so critically important, but you must complete an evaluation in order to receive your credits. And we will include a link to the evaluation at the end of this session. And then you should see your certificates within 2 weeks. And you can request updates, or if you have questions, you can contact Liz about that, and she can drop her email in the chat. And as far as questions and answers go, we really encourage you to participate. You can also just add comments in, or if you have questions, but we are asking folks to use the Q&A feature in the Zoom as a way to interact with us, and then we will address, or Katie will address questions at the end of the session. So without further ado, it is my pleasure to introduce you all to Dr. Katie White, and she is an assistant professor of medicine at Vanderbilt University Medical Center in the Division of Infectious Diseases. Her career interest is focused on the intersection of infections and substance use disorders, and she treats patients with substance use disorders in many clinical settings, including the Vanderbilt Comprehensive Care Clinic. And Katie shared with me this morning that she's kind of coming back home to the world of HIV very recently. So we are just so pleased to have her back in our fold and for her to be presenting with you all today. So, Katie.
Dr. White, please unmute yourself.
I did that. Thanks, everybody. Thank you so much for that introduction. I'm so excited to be here and watching everything come in through the chat box about who's in the audience. It's really invigorating. I feel like I could learn so much from all of you. So I hope we have a good time today talking about collaborative approaches to caring for patients with substance use disorders. I have no disclosures for this discussion. And I'm hoping that after this discussion, we will all be able to define addiction and substance use disorders, discuss the chronic disease model of addiction, explain the role of medication in treating addiction, and then also have a conversation about the rationale for new and systemic approaches to clinical management of patients with substance use disorders. I included just a few slides highlighting the need for this, and I'm sure this is not lost on anyone in this audience, but in our region and across the nation, obviously we are seeing an increasing number of drug-involved overdose deaths. These data are from the CDC, and you can see over time we're seeing obviously an upward trend in overdose deaths from 1999 to 2019. Importantly, these data don't include 2020 and then 2021, where in our region and elsewhere, we're seeing a marked increase in overdose deaths in the context of COVID-19. There's an exceptional need for folks interested in treating patients with substance use disorders and helping to minimize risk in that context as well. So this is an important conversation today. Also importantly, when these trends are broken down based on the type of substances involved, you can see that really a lot of what we're seeing in more recent years is driven by the influx of synthetic opioid products into the drug supply, particularly fentanyl. And this is obviously a much more potent and potentially deadly substance. So the trend of our overdose deaths unfortunately corresponds with increasing access to fentanyl in the illicit supply. And then as we're talking today, I think it's important to keep in mind that the need is large for patients with substance use disorders, and then there's an enormous treatment gap. So we are faced with a tremendous opportunity to make a difference in helping these patients. This slide was taken from a SAMHSA presentation on the National Survey for Drug Use and Health that was put out, I think, in May of this year. So this is 2019 data. And for this part of the conversation, focused on the substance use disorder bar and then the co-occurring any mental illness and substance use disorders. And you can we have a large number of folks who are struggling with SUD. About 20 million estimated, and that the treatment gap, there's about 90% of these patients who are not receiving treatment for this problem. Similarly, for patients who have co-occurring mental illness and substance use disorder, about 90% of patients aren't accessing treatment. So this is where our services could really come into play. So for today, I think it's important that we consider that substance use occurs along a spectrum. So obviously you have people who are using substances, abstainers at the very far left end of this spectrum, patients or people who are using substances in a very low risk fashion, and then also risk increasing where there's hazardous substance use but not yet meeting diagnostic criteria for a use disorder. And then as we move across this continuum, there are criteria that are listed in the DSM-5 where we can formally diagnose a substance use disorder, and this can occur along a continuum of severity. This is important because, as we mentioned, substance use disorder is highly prevalent. About 20 million Americans have a substance use disorder. These patients present in a number of care settings, and they often are not asking for help related to their substance use disorders, but making a diagnosis could be very important and life-changing for those patients. And that only about 10% of these patients are receiving treatment for an SUD. So what is addiction? And this is something that there are multiple definitions put forth by societies and groups that are working in this field. ASAM describes addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations, and this is reflected in individual pathology pursuing reward and or relief by substance use and other behaviors. I think this is a beautiful description of the disease process we're working with, and this paradigm kind of should shift the way we think about how we approach treatment for these patients. And we'll dive into this a little bit more in future slides. Smart Recovery says this in a much more succinct way. Addiction is maladaptive behaviors with physiological underpinnings. And then one thing I wanted to focus on for this talk is the idea, the paradigm that I think that the field is moving towards is that addiction is a chronic brain disease that can be effectively prevented and treated. And while to many of us in this audience, because I saw a lot of folks joining from behavioral health fields and recovery fields, this may not be a revolutionary concept, but when you go out into general medicine, this is not the way addiction has traditionally been considered. And so I think it is important as we work in the communities with our patients and with other practitioners in other disciplines to try and promote this idea that this disease is analogous to other chronic diseases, should be treated as such, and that comes with a sense that we can do something about this, that we can manage this in a similar fashion to the way we manage heart disease, diabetes, high blood pressure, those sorts of things. HIV, let us not forget. So let's talk a little bit more about the chronic disease model of addiction. While we're thinking about this new paradigm, I think it is important that we have an understanding of the basic neurobiology of addiction. So there's an extensive body of basic neuroscience literature on this topic. I really like the model that is put forth by Drs. Wise and Koo, both of whom have worked to map the neurocircuitry involved in addictive behaviors and the neurotransmitters involved in these signaling pathways. And they describe a positive reinforcement pathway that leads to the initial repeated use of the substance. And this would be the use that leads to the euphoria sensation or the escape. But it is what drives that initial return to substance use. This maps to very specific anatomic regions of the brain. And over time, this repeated stimulation secondary to substance use leads to decreased function of these systems in response to the stimuli that would normally provide reward. Concurrently, ultimately, this leads to increased substance use to try and stimulate those positive reinforcement pathways. In parallel, there's a negative reinforcement pathway. It's a separate system that mediates negative consequences when the substance is not used, and this is associated with the withdrawal states. So very obviously, a patient who is using opioids for a long time, there's a very dramatic and easily identifiable clinical syndrome that is encountered when a patient doesn't have access to opioids. And that often becomes or is a major reason why a patient returns to use, is to try and avoid this negative reinforcement. Finally, ultimately, the sustained substance use impacts the patient's executive functions. And so this is where consequences of the deficits in executive function over time leads to turmoil in their personal lives, fractured relationships, housing and food instability, legal trouble. All of this reinforces this cycle of use to try and activate the positive reinforcement pathways, avoid the negative reinforcement consequences of not using substances. Further, we know that there's heritability in substance use disorders. So this is a study that was published in JAMA, and it looked at studied twins to identify proportion of risk for chronic diseases that could be attributed to genetics. And essentially what you see is that for substance dependence, heroin, alcohol, and marijuana, the rate of, or the proportion of risk for this chronic disease that could be attributed to the genetics of the patients was in range with what we find for other chronic diseases, high blood pressure, type 1 and type 2 diabetes, and asthma. So this again is contributing to this idea that we should be thinking about substance use disorders in the same fashion that we think about other diseases that we manage chronically for patients. And that leads to this corollary. So addiction is a chronic brain disease that is preventable and treatable. We should approach it with the same lack of stigma that we talk to our patients about their coronary artery disease, and the same robust screening and assessment. And then the treatment modalities, at least in concept, are largely the same. So prevention and treatment are two of the main things we'll talk about today. One important goal of shifting the paradigm to thinking about substance use disorders in this chronic disease model is that this would be a destigmatizing move. So we all know that our patients experience a lot of stigma coming from the HIV field. HIV now and historically has been a stigmatized diagnosis, which is very unfortunate. Same way with substance use disorders, stigmatized to a degree that other chronic diseases are not. If we shift our thinking here, we can start to break down this stigma, which will help us engage patients, treat patients with more compassion, and also from an evidence-based perspective. And if you look at the comparison in this table, you can see that in both cases for coronary artery disease and SUD, there are environmental and behavioral factors that contribute to the disease process. There's a heritability component. There are co-occurring disorders that need to be managed in order to successfully treat the chronic disease. There are diagnostic tools for screening as well as for confirmed diagnosis. I would argue that the screening and diagnosis for SUD is by far potentially easier and less costly than what you need to go through to identify a patient with coronary artery disease. There are prevention and risk mitigation interventions that we need to take in both cases. And then this last box, the treatment. In both cases, there's medical treatment, behavioral and social support, symptom management, and intensive follow-up that contribute to how you approach managing the chronic disease. Always include a slide about how we talk about this. So we are taught in medical school and forward to avoid stigmatizing language when we talk about other chronic diseases. And it should be that we exercise those practices when we talk about the chronic disease of SUD. So terms that have been traditionally or commonly used, such as addict and abuser, substance abuse, substitution therapy, clean, dirty, detox. There are preferred terms that remove the stigma from the conversation and allow us to focus on the respect, dignity of the patient. Talk about this in much more of an academic capacity as we talk about other diseases. And then ultimately that should allow us to approach patients in a much more compassionate way. So in general, if you want to just kind of read through some of these charts, and the next time you find yourself talking about a patient with SUD, try very hard to teach yourself and your trainees, particularly your trainees, to adopt a language that respects our patients. Preferred terms would be person with a substance use disorder, obviously SUD as opposed to abuse. This is a stigmatizing term. Talking about how we treat OUD, for instance, instead of saying substitution therapy or opioid replacement therapy, it's agonist therapy, which is essentially what we have when we are using an ACE inhibitor to treat blood pressure. So make those connections. Finally, detox is something that we say a lot. And in fact, I think this is important because if we think about SUD in the context of a chronic disease, there is no one and done, you're over, it's fixed, we detoxed you. Withdrawal management, this is step one for some patients, but then the actual treatment goes obviously much, much further. So pushing forward with this analogy, step one in making these diagnoses is our screening. So obviously in both cases, an important component is history and physical exam. And then having access and knowing how to use screening tools is very important. These need to be quick, part of routine care, and available to use in any healthcare setting. I won't spend much time on the individual screening tools, but a couple I really like and would try to encourage you to incorporate into your practice are the NM Assist tool that NIDA published, and this is available online. You can just Google this and then click through as you're talking to your patient. And essentially it screens for SUD across a spectrum, and then at the end of these questions, it'll sort of pop out a risk level for a substance use disorder with a brief little blurb about what you might want to consider to do next. And similarly for alcohol use disorder in specific, the Audit C is very helpful. So if there's a way to sort of incorporate this into your workflow when you're interacting with patients, again, you know, only 10% of patients for substance use disorder are in treatment. Patients are presenting it across all different care settings. And so having these tools available to identify a potential patient with an SUD is critical to link patients to care. Then we make our diagnosis. So in the setting of coronary artery disease, we might do one of these sort of invasive or highly expensive testing, stress testing, angiography, echocardiography. In our cases, we can rely on DSM-5 criteria where you can walk through and in a very formal way, have the patient answer questions about their use, and then determine if they actually meet criteria for a substance use disorder and whether it's mild, moderate, or severe. This is important because we take a lot of time to exercise precision in our diagnosis for other chronic diseases. I would argue that doing the same thing for patients with substance use disorder is important as well. And I'm sure you all agree. So then linkage to care. And this is where I think things get really interesting because there's no one size fits all solution for this. I like the way ASAM thinks about this. This is American Society of Addiction Medicine. And they talk about how matching patients with SUD to treatment has evolved over time. And still in some parts of certain medical settings and historically, a complication-driven treatment approach was really standard, meaning a patient presents with a complication of substance use, a fracture, an overdose, a bleeding esophageal varice, for instance. And then this problem is fixed. And then the patient is essentially discharged after they were stabilized from this acute event with little or no treatment offered for their use. Obviously, this doesn't help the patient prevent another complication or treat the underlying disease. A diagnosis and program-driven treatment concept does recognize that SUD is the root problem for whatever the presentation is, but the treatment plan, the level of care, and how long the patient needs to stay in treatment is determined by the diagnosis. So for instance, a patient presents to the emergency department after a heroin overdose, and the recommended treatment, the only recommended treatment is that the patient attend a 28-day residential treatment program, which may be the best spot for that patient to land. But in terms of thinking about the patient as a whole, that may not be what the patient is ready to do. And there may be other options to engage that patient that could make a difference in their substance use disorder. So ASAM argues for moving towards an individualized assessment-driven treatment model, where the treatment plan is determined by both the severity of the patient illness and the patient's level of function. And this can be assessed across 6 dimensions. So this is the multidimensional assessment algorithm that ASAM recommends. And essentially, it walks you through kind of different aspects of the patient as a whole. Obviously, the first one is whether or not the patient has acute intoxication or withdrawals or has the potential for those. And, you know, those states often require a certain level of care to manage medically. But then also consider the biomedical complications of the patient. Do we have other medical problems that are contributing to substance use or would be a barrier to a potential type of treatment program? The behavioral health of the patient's motivation and readiness to change. You know, the patient may not be ready to immediately move to a residential treatment program, but they might be ready to engage in intensive outpatient treatment, which is a step in the right direction and certainly something that you would want to offer the patient if they're willing to accept. And then recovery and living environment. What is the potential that the patient will be successful in recovery if they do exit the emergency room and go home versus go to a residential treatment or other level of care? And then they also talk about incorporating outcomes in this. So outcomes, meaning that the model, the individualized treatment model, focuses on these dimensions and tries to match the use with where the patient is. But having an iterative process where at individual point or at regular intervals as the patient is moving through treatment, there are outcomes that are measured. And that allows the treatment plan to be more flexible and responsive to each individual patient along their journey in recovery. And I will say that these 2 models require that there be a continuum of resources available to patients. And this is where things get really hard and where we at Vanderbilt and other centers across the country are working really hard to sort of build a network of service lines where we have the capacity to move in a flexible way as we know our patients in their particular journey. So we have linked our patient to an appropriate level of care, and now it's time to think about how we manage this chronic disease. And again, I want to highlight that if we're destigmatizing substance use disorders, making it analogous to another chronic diseases, the basic categories of interventions and treatment are exactly the same, and they're listed here. So I'd like to start with the role of medication-assisted treatment in the treatment of addiction. And this is something that I'm sure is well understood amongst this group, but I think, you know, for when I'm talking to trainees and others in medicine that may not be quite as familiar with how substance use disorders are treated, this is something that it's important to be able to discuss fluidly as we start to think about a multimodal treatment approach for SUD, just like we do other chronic diseases. So it's important to remember that various treatments work for relapse prevention for all substance use disorders. And there are certain substance use disorders where the effect size for medication interventions is very large, meaning that for opioid use disorders with buprenorphine products, we do know that does have a dramatic effect on a patient's early recovery and retention and care. Similarly with nicotine replacement therapy for patients who smoke. And in this case, it's important to remember that it's growing to be standard of care that a medication component when the patient is willing to do this is important for that treatment plan. Not to negate the role of psychosocial treatments, these are also very important, but at least moving in initially, medications do have a very large effect size and can lead to patient retention early in recovery. Unfortunately, for many substances, we don't have a good medication assisted treatment to offer patients. So stimulant use and cannabis, for instance, are two very good examples where the effect size for medications that have been trialed in methamphetamine, cocaine use, for instance, are much smaller than what we see for buprenorphine and OUD, for instance. And therefore, the treatment plans rely very heavily on psychosocial treatments. In both cases, there might be a role for each of these components, but the proportion of the treatment plan sort of relies on one or the other is variable depending on the diagnosis. An alcohol use disorder incorporates both and many times. So if we think about medication in the context of these of substance use disorders, so how does what we talked about in terms of neurobiology impact the way we think about prescribing for addiction treatment? So we can target reward pathways. Remember, this is one of the pathways that where we develop dysfunction in the context of repeated substance use. You can use blocking agents. So in the context of alcohol use or opioid use, naltrexone. So essentially you're blocking that rewards function with substance use. You can use agonist therapy. So in the context of OUD, methadone and buprenorphine, safer ways to administer an agonist than the heroin or fentanyl that the patient had been using prior. And it does block the reward pathway, meaning, longer acting opioids at the receptors that don't turn that light bulb on as much, are both safer, and they provide that patient, sort of a stabilizing reward sensation. And then treat underlying reward system disruption. So if a patient has a co-occurring disorder that is affecting the reward pathway, the function of the patient's reward pathway, treat that as well. Depression would be a good example in our patients. We can target the stress pathway, so the negative reinforcement pathway. We can work to help the patients with withdrawal management, decrease withdrawal symptoms. And this might be opioid agonist therapy for OUD, GABA modulators for alcohol use disorder, like benzodiazepines in the acute setting, and then longer term we have other agents that do this. And then again, treat underlying comorbid anxiety and other disorders that might be triggering these negative reinforcement pathways. And then target executive functions. So if there is concurrent ADHD or bipolar disorder, then treating these disorders as well are very important. And all of these interventions do require or could require a medication to assist the patient in their recovery. Thinking about opioid use disorder in a little bit more detail as sort of a model for how we might craft this treatment program, we have 3 FDA-approved medications for OUD, methadone, buprenorphine, and naltrexone. Each of these has slightly or different characteristics in terms of how they act in the disease process and how they are administered in the community, for instance. And so you can sort of tailor a patient's treatment program based on their willingness to participate in one or the other type of program. Methadone is a full agonist opioid receptor. It is prescribed in a very highly structured and supervised setting, which is beneficial for some patients who need this additional structure around them. We can provide additional services on site, and we can supervise the patient so we know that diversion potential for this treatment is much lower. We consider methadone as effective for patients who have not benefited from partial agonists like buprenorphine or antagonists such as naltrexone, and for other reasons as well when we're thinking about a patient's plan. Buprenorphine is well known to many in this audience, I'm sure. Important characteristics of buprenorphine is that it's a partial agonist at the opioid receptor, meaning it binds with very high affinity to the opioid receptor. Because of that, it will block binding of full agonist opioids, such as heroin or fentanyl, short-acting opioids, for instance. It is a partial agonist, so it does not stimulate at the opioid receptor to the same degree as a full agonist, which allows us to have a very favorable safety profile for buprenorphine use. And it's very long-acting. So, patients describe when they are using short-acting opioids such as heroin, this cycle of reward and withdrawal, just kind of the seesaw pattern that puts them in the spiral of repeated use in order to manage both of those two components. With buprenorphine, you get this nice, even, steady sort of blood level of the drug, and patients report that it is very much an evening out of the way they've been feeling prior to that. Importantly for buprenorphine is this really does open up how we can treat patients in the outpatient office-based setting. And so this has been very beneficial to many of our programs. Naltrexone is a full antagonist. There's no overdose potential. There's no addictive risk. It's available in office-based settings, and it comes in a depot injection as well, so that can be nice for some patients. It's sometimes difficult to initiate naltrexone because a patient needs to be fully off of an opioid before starting this medication. And so with these others, we can initiate prior to the patient moving through the full withdrawal syndrome. So in terms of buprenorphine and how this is used in management for opioid use disorder, there have been plenty of studies looking on the effects of buprenorphine versus placebo or other agents in terms of treatment retention and outcomes for patients with OUD. This is a nice study from 2003. It was rather small, 40 subjects included, but it did look at patient retention and care for patients who were treated with buprenorphine versus a placebo product, and everyone receiving intensive psychosocial support. And what they found is that at 1 year, patients who were treated with buprenorphine were retained in care at a very high rate, whereas patients who received placebo with psychosocial support were lost to follow-up rather quickly. And in fact, 4 of the 20 patients, unfortunately, in the placebo arm died during the study. So this was good evidence, or it is one of many studies showing that there's good evidence that the effect size for medication in the setting of OUD is large. And this might have a very positive outcome for patients in treatment. Similarly, looking at patients' retention and treatment for patients who were maintained on buprenorphine across 14-week study versus patients who were started on buprenorphine but then tapered at various intervals, it does appear that when patients were tapered off, their treatment retention rates went down quite dramatically. So this brings up the question that we're always asked is, how long do you treat patients with buprenorphine? And there really is no answer to this question. The evidence is variable. There are many studies showing high relapse rates when the medication is withdrawn. Up to 16 weeks, patients were followed in some of these studies, and improved retention rates in treatment with extended buprenorphine prescription. So our practice at Vanderbilt is that we continue maintenance dose buprenorphine as long as the patient is benefiting from the treatment. And we define this differently, the same and differently for each patient. So decreased substance use is obviously a primary goal, but is the patient meeting their employment, their educational, their relationship goals? Are we working on crafting a recovery community and environment around the patient where the stability of having medication is allowing us to build that arm of their recovery plan? And in that case, we keep patients on medication. This is very much something that is a individualized recommendation for our patients. And when patients approach us and want to taper methadone very quickly in their treatment, we do talk to them about the data that we have, the potential risks of doing this, and then make sure that we're working together to come up and ask the question whether or not this is the best step or the right time for their treatment. Again, this is not unlike other chronic diseases where we use medications for an extended period of time. So as long as it's being used safely under the care of a physician that's taking care of the patient, then this is something that I would advocate for. So the next component of a chronic disease management is behavioral and social support. So we talked about medication already. This is, we're controlling cravings, we're preventing relapse. This is part of our treatment plan for the substance use disorder diagnoses where we have this option. Equally important to managing SUD is behavioral and social support. So this is a biopsychosocial approach to treating this disease. We treat the biology, we're working with medications to try and make the patient feel better. And then we start to incorporate, or we from the get-go incorporate treatment for psychosocial to treat the psychosocial issues that the patient is facing. So counseling is very important, teaching patients about addiction. What does your diagnosis mean? And then what does recovery look like? What are the components of recovery that we can help you with? Relapse prevention skills, and then treatment of psychiatric comorbidities is very important. And then community supports. So peer support meetings, sober social networks, family supports. And again, these things sometimes take quite a bit longer to develop and nurture in a patient. And this is where having a medication that's stabilizing at least the biological component of addiction can be very helpful as the patient is doing these other domains. For chronic diseases, we treat co-occurring disorders. So putting up the SAMHSA slide again, the patients, the number of patients who have co-occurring any mental illness and substance use disorder in the United States is estimated to be almost 10 million patients. Very important that we manage these co-occurring psychiatric disorders in order to give the patients the best shot at recovery from SUD. I'd also like to mention that don't forget about acute and chronic pain. These are conditions that put patients at high risk for relapse over time, particularly for opioid use. And if there's a way to sort of work in a safe pain management plan into patients, into their relapse prevention plan, that's very important. And then very close to our hearts is chronic infections. Diagnosing and treating HIV, hepatitis C, those sorts of things as well are very important to successful outcomes for these patients. Risk mitigation. We do this for coronary artery disease when we ask patients to help patients try to stop smoking, lifestyle changes with diet and exercises, etc. For SUD, this is, we do the same thing. This is harm reduction, essentially a battery of practical strategies and steps to reduce the negative outcomes from the disease. So for all patients, no matter where they are in their recovery, it's important that they have education on overdose and prevention, a naloxone prescription, information about never using alone, which increases risk of death from overdose, safe injection education and access to syringe exchange resources where available, testing for viral hepatitis and HIV, and then PrEP and vaccination as well. So a harm reduction bundle is very important as part of the chronic disease management for our patients. And then finally, when we move into this longitudinal or the thought of treatment across the continuum of patient presentations, what are the systematic approaches that we might undertake to sort of better support patients with these chronic diseases? So thinking about this from a traditional perspective, and I'm sure you've all seen patients that move through a continuum that looks something like this. If we start up here in the acute hospital setting and a patient comes in with cellulitis at an injection site, they're admitted to the hospital for treatment of this acute infection. Hopefully that psychiatry is involved in their service at some point to help link them to care for substance use disorder. We are recognizing SUD as an underlying diagnosis for this presentation of cellulitis. The consult service treats the patient in the hospital. The psychiatrist for substance use disorder helps them with withdrawal management, for instance, and then their patient is referred to an outpatient addiction treatment program to make contact with once they leave the hospital and they're discharged. For many of our patients where executive function has been affected for the lifetime of their use or recently, There are transportation, financial issues, the ability of the patient to actually engage with the piece of paper in front of them and make the calls for the phone numbers may or may not be there. And what we find, and many folks have observed, is that this leads to a situation where no appointment is made, there's no primary care or health center involved, and the patient ultimately doesn't follow through. It's a very overwhelming situation for many of our patients. And because of this, the patient does not get the care they need. They continue to inject, and then they come back to the emergency room with heart failure and a fever and a new diagnosis of endocarditis. So how can we address these fractures in care? This is where we identified these transition points as being very high risk for this vulnerable patient population. So what Vanderbilt is doing, and what many medical centers around the country are doing right now, is to try and redesign this continuum to position persons with substance use disorder expertise at multiple points across this journey. So one, the patient presents in a similar fashion, but we have a dedicated addiction consult team in the hospital. And there's been plenty of literature written about the role of addiction consult teams on the inpatient setting. Many hospitals have incorporated this. Then we have found that this has been extremely beneficial to patients and also our other medical providers in the hospital to support specifically the substance use disorder diagnosis that is driving many of the presentation and patient behaviors. We have a social worker with expertise in how to help a patient navigate the world of recovery, very knowledgeable in what levels of care are available to the patient, and can think about how to incorporate that with what the patient has to offer. Do they have a car? Do they want to do this? Do they have, financial obligations that prevent them from immediately moving into a very high level of care, residential treatment, or something analogous? And what options would be available if option A is not, for instance. We've positioned a very low threshold bridge clinic immediately at the discharge of patients. And this is a concept that is gaining speed around the country too. Our bridge clinic is modeled after other the bridge clinic at MGH, for instance. And so you're seeing this idea pick up, which has been transformative in the way we're able to help our patients at Vanderbilt. And I'll tell you a little bit more about what we're doing in this space at our medical center. Importantly, we have recovery coaches, peer coaches positioned throughout this continuum. So they're meeting with patients when they walk in the door uncomfortable with withdrawals. They're meeting with patients very early in recovery when they come to Bridge Clinic. They're meeting with our patients once they move through more of the longitudinal steps. And then forming relationships with our community partners, trying to educate and promote general medicine and primary care practitioners to work with our patients with SUD and feel comfortable, for instance, with buprenorphine, if that's part of the patient plan, et cetera. And our goal, obviously, is to prevent readmission, morbidity, and mortality, hopefully launch these patients into a more successful recovery path. So what resources do patients need? This is a very common phrase now, but it is very true. You have to meet patients where they are. You cannot expect patients to sign on to a treatment plan that is outside the scope of what they're able to do at that point, or what they feel they need based on their assessment of their use disorder. And working with patients in an iterative fashion to help them understand their diagnosis so that you and the patient can craft a treatment plan that is mutually acceptable is the most important thing. So how we interrupt this traditional model. In the acute setting, patients are in the ED. Having buprenorphine waivered or trained providers positioned in the emergency department or the psychiatric emergency department, anywhere where there's sort of a walk-in emergent need, is very important. Folks trained to make a diagnosis and then offer a stabilizing treatment at that moment is critical. Trained social workers in this context as well. And all of these folks are providing assessment and MOUD initiation and then referral. Hospital setting, we talked about the addiction consult service, education to promote understanding of the chronic disease of substance use disorder among all providers, And then collaboration amongst disciplines that commonly touch these patients. So our addiction psychiatry and ID teams, for instance, work very closely together because so many of our patients are the same patient. And so we need to understand how we're approaching the patient from our different disciplines and learn from one another. Oops. A low barrier bridge clinic that is multidisciplinary and has wraparound support. I'll tell you about this in a minute. Longitudinal clinics at various levels of ASAM care are important more and more to try and incorporate some of this treatment for certain patients into a primary care setting would be beneficial. And then obviously access to higher levels of care, which is something that can be very challenging. It is in Tennessee. But having access to residential treatment programs and inpatient treatment programs for patients who do need this. So the inpatient addiction consult service at Vanderbilt and other places includes medical providers, so attending physicians with expertise in addiction. In our case, these are addiction psychiatrists, as well as mid-level providers, nurse practitioners, APRNs, and then trainees. So we try very hard to encourage fellows and residents and medical students to rotate through this training environment to help form their medical education around some of these destigmatizing concepts of SUD and understand how to treat it. They are doing many things in the consult setting, including withdrawal management, assessment diagnosis, and motivational interviewing to help the patient understand their diagnosis and form a treatment plan for after discharge. Case managers play an integral role here. Social workers are working with the patients for brief interventions, needs and motivation assessments. And then both case management and social work are coordinating the transition of care. And then importantly, again, I mentioned our recovery coaches. This is one of the components of our addiction treatment programs that I think is kind of the secret sauce. The recovery coaches are phenomenal. I'll tell you a little bit about the program in Tennessee, but they are folks who are in recovery themselves and then certified and trained to be a recovery coach. The way that the recovery coaches are able to interact and meet our patients is just phenomenal. And I do feel very strongly that this has led to much more positive outcomes than if we did not have those folks as part of our team. So everyone in the inpatient setting is working to make a patient-centered assessment that matches treatment to patient needs and motivations. At discharge, some patients have the opportunity to follow up at our Bridge Clinic. The Bridge Clinic at Vanderbilt, every patient is prescribed MAHEWD if that's appropriate for their diagnosis. They get a psychosocial assessment, behavioral interventions, recovery coaches, coaching, screening for viral hepatitis and HIV. We give vaccinations where indicated, case management and social work support. It's a transitional clinic, so most patients spend about 3 months in our clinic, and what we're doing at this point in time is just trying to stabilize things in early recovery and assess what is the need and what would be the next most stable way to allow the patient to continue in their recovery journey. Does it need to be a clinic close to home? Do they have insurance? Do they not have insurance? How do we negotiate that and have time to do that thoughtfully? And while that's happening, our clinic includes addiction psychiatry attendings, pain medicine attendings, infectious diseases attendings, and primary care. So we move the patients around our clinic sort of for mini consults as we identify areas that we feel put the patient at risk or for issues that need to be addressed so that everyone can sort of contribute to a holistic plan for the patient. I mentioned that our goal in this Bridge Clinic setting is to allow patients easy and quick access to the clinic, regardless of payer status. We take patients without insurance, provide them with wraparound service, and then work really hard to find out what the next best step would be and provide a warm handover. So when it is time to move a patient to a longitudinal clinic, we write a discharge document and communicate with the intake provider to try and best support the patient for that. The peer recovery supports. So many states, I'm sure, have this capability. At least all the states in the SEATC have through the state a certification process for peer recovery specialists. Ours is run out of the Department of Mental Health and Substance Abuse Services. And these are folks who are in recovery, sustained recovery from SUD. They work through this certification process so that they're able to work with patients in a clinical setting. So there's HIPAA training, ethics training, motivational interviewing training, brief interventions, et cetera. And then essentially their role is to help patients navigate their recovery. And the fact that there is a peer relationship, our patients have commented over and over again that this is a critical component to their success in early recovery, that there's someone that really understands what they're going through and is with them at that time. So when we have a multidisciplinary setting like we've developed, what can we do with this? So there's a couple programs that we've built in that I wanted to just share quickly. One of them is our OPAT program. So OPAT stands for Outpatient Parenteral Antibiotics Therapy. So essentially this is allowing patients to go home with a PICC line in their arm and complete their antibiotics at home. There are many centers who are working providing OPAT services for patients who inject drugs, but it's not something that is terribly widely accepted at this moment in time. We argue that this is better for some patients. You know, often the home environment is more restorative than staying in the hospital for 6 or 8 weeks, however long the treatment antibiotic treatment program is. This allows patients to get more intensive treatment for their substance use disorder earlier in their recovery. Often in the hospital or skilled nursing home, there is no recovery support for these patients. And so for that window of time, their SUD is essentially going untreated. And that's a tremendous missed opportunity. There's motivation in that window. This is something we should be treating. And it provides an opportunity for patients to participate in their healthcare, which leads to empowerment and a sense of self in these early phases of recovery. Obviously, if when we do this, we save hospital and SNF days, so there's an economic motivation for this and a decreased risk of healthcare acquired infections. This is not something that we are undertaking in a vacuum. There have been studies examining outcomes for patients who inject drugs versus patients who do not inject drugs, who complete OPAT programs. And so these studies are in the literature. So the IDSA has journals that have published extensively on these topics because it's of great interest. This was a literature review looking at outcomes for patients who inject drugs and those who do not, but went home with OPAT for their extended antibiotic therapy. And what you can see is that if you compare the two groups, the outcomes are not very different. So treatment completion rates are analogous. Readmission rates were higher in the PWID group. But if you look at for non-PWID for these very serious diagnoses, SSTI, endocarditis, and osteomyelitis, which is where our patients, the infections our patients typically have, the rates are comparable. PICC-related complications were low in both groups. So at least looking at these 10 studies analyzed in this literature review, this appears to be a safe intervention. This is becoming more and more common. So 84% of OPAT centers internationally are providing OPAT to patients who inject drug. And obviously there's cost savings when OPAT's an option. There are also studies looking at whether or not patients do better if they go home or if they go to a skilled nursing facility. And what you can see is that there is no statistically significant difference between outcomes for the patients who went home to complete their antibiotics and those who went to a skilled nursing facility. So the a priori assumption that SNF discharged is safer or better for all patients is not necessarily true. It is true for some, but not necessarily for all. So one thing we've been able to do because of our close relationships with psychiatry, ID, the Bridge Clinic, case management, social work support, and peer recovery coaches is put together a care bundle for patients who might qualify for OPAT. And essentially this is weekly visits at our Bridge Clinic with our full recovery team. Prescriptions, so patients are treated with buprenorphine for their opioid use disorder. They get home health support and then phone contact with patients. And right now we're working to collect data on this to show that, to examine how we're doing when we apply this patient care bundle. Anecdotally, I will say that obviously there are some cases that have been challenging, but by and large, we've had great success with this and patients do appreciate being able to stay to go home, recover at home, and then be more engaged in treating their SUD from the get-go. We're also incorporating hepatitis C treatment into the Bridge clinic setting. I mentioned that most patients spend about about 3 months in the Bridge clinic window, which is a perfect amount of time for patients to complete treatment for Hep C while we've got them in this transitional period. And so for patients who meet criteria for the simplified treatment algorithm from the IDSA, we are working, we have protocols in place with infectious diseases and case management to work to get those patients the medications they need and treat their Hep C. This is somewhat novel, sort of having an addiction clinic, a transitional addiction clinic where we're offering full Hep C treatment in that setting, but good for patients. So lastly, I'll say that I'm so happy that we're thinking about how to work together on this problem. I will say that one thing that is important to remember and that I learn on a weekly basis is that the goal for our patients in recovery, early recovery particularly, may not be immediate abstinence. This may not be something that is a realistic goal. But if you think about this from a chronic disease standpoint and the steps that we take to manage those diseases, we mitigate risk. So we talk to our patients about harm reduction. We know that any decrease in use is helpful for the patient. It leads to fewer complications. And this is the same for our coronary artery disease patient who needs to smoke fewer cigarettes. They may not be ready to stop, but they smoke fewer. They lose 5 pounds instead of, on their way to losing many more pounds. So this is not always a light bulb on, light bulb off thing, and being comfortable with that is very important. And ASAM says that in the event that a patient's self-reported substance use differs from the results of their drug test, the provider should use the discrepancy as a springboard for therapeutic discussion. So this is the other component. Abstinence may not be immediately possible. So when the drug screens show up and there is something in the urine toxicology that signals use, that is a moment that's an opportunity to advance the conversation, advance the therapeutic relationship with the patient. And, we don't view that as a reason to determine that the patient's not able to continue treatment with us, for instance. So I would view some of these things that have traditionally been hard for many practitioners to accept as opportunities. And that's based on ASAM's guidance as well. So with that, there are so many people at Vanderbilt to thank for this, as well as the SEATC and you all for inviting me today. I do want to highlight that the leadership in the Division of Addiction Psychiatry at Vanderbilt is the main driver behind all the programming I talked to you about today. And I've just been lucky enough to be invited to participate in the care of these patients. And they've extended a hand to infectious diseases to say, let's work together. But David Markovitz and Christopher Cass are just wonderful people and doing a lot here at Vanderbilt to help patients with SUD. So with that, I'll stop. We can take questions if you have any. I think we've got we have almost no minutes. I'm so sorry, y'all.
No, great. No, great job, Dr. White. Awesome job. There are a few questions. So Carolyn in the Q&A pod, she did ask if the ASAM treatment approach recommendations will be something that will be widely disseminated. She said that they see a lot of people in the field wish trying to place a patient in an inpatient facility.
Yeah, so that it is. So if you Google, let me go, oh no. If I go back to that slide, if you talk about the multidimensional, this is available widely. This is what ASAM puts out as their recommendation for how to assess a patient to match treatment matching. Oh no, now I just sent us into its tizzy. I'm so sorry, y'all. That little slide that walks through each of the 6 dimensions, you can find that online. So that is something that they do advertise. The descriptions of each of the layers of treatment or the evolution of the treatment recommendations, it comes from their textbook. And so that is something, I'm sure you could find it online, but the description I thought was so nice and so helpful as, sort of conceptualizing this. And that comes from the Principles of Addiction Medicine textbook directly. I agree with you. I feel like that is sort of a knee-jerk reaction that, residential is the answer. And for many patients, it is the answer, but not every patient. And it's so unfortunate if there's a patient that might say, yeah, I'll come to clinic. And at least they want to talk about their use. They want to, baby step this forward. That's better than, no, I can't go to residential. And so there's no alternative. So I think that's something that I hope changes.
Dr. White, there was an additional. Oh, go ahead, Vanessa.
I was just saying my internet is unstable, so I'm going to turn off my video, but go ahead, Liz.
Dr. White, there was an additional question in the chat pod from Kenneth. What are the drug side effect risk from these substance use disorder meds as you keep the patient on the meds as long as there is a positive therapeutic effect? The
side effect profiles? Is that the question? Yeah, so there aren't, meaning, we do have patients who report that they've had an allergic response to, buprenorphine in the past and that sort of thing. In clinical practice, honestly, I see patients tolerating these products very well. I've never had a patient come in with a rash or any kind of complication. And essentially, if you think about it, buprenorphine is an opioid. So it's acting on the opioid receptor in the same receptor that their heroin had been acting on the day prior, or actually you probably want to get a little further into withdrawal. So a couple days prior. And that being said, so in terms of, how you would choose a pure buprenorphine product versus a combined product like buprenorphine naloxone, there are considerations. Buprenorphine alone is preferred in pregnancy. And if, patients with severe liver dysfunction, naloxone is not advised. So there are some nuances like that. But in terms of tolerability, patients feel so much better. And then dose titration is something that we work on early. This is the beauty of having a weekly bridge clinic, is that you can see patients in very short intervals to assess and say, okay, you're on 12 milligrams of buprenorphine. How did you feel this week? What do you think about your dose? And so we can sort of modify the dose overall for the patient in a more flexible way than some other clinics can do. So patients feel really good on it. They come in and they say, this is the first time I felt normal in a very long time. And it's because they're exiting that up and down, up and down, up and down cycle that they had been in prior.
That's wonderful. Thank you so much. And thanks to so many of you that have stayed on after the top of the hour to get through this with us. So I just want to please, again, much gratitude to Dr. White and to all of you for joining us today. Liz did send out the link to the evaluation. It will also be sent via email. The slides will be posted, as will the recording. So please feel free to share it with your colleagues, and please join us at our next session as well. And Liz put information about that in the chat. So just thank you all so very much. Have a great day.
Thank you. Appreciate it, y'all.